Thank you, Robin. I really appreciate the opportunity here to speak to everybody and hear what everybody has to say. A little bit about our practice here in Oklahoma. We have one surgeon, Paul Jacob, and three PAs. So we try to keep 2 PAs in clinic and him in the OR 5 days a week. So that's been great up until this pandemic. And we call it the pandemic +1 because Dr. Jacob was actually in Hawaii on vacation the week before we got shut down on elective cases. So we've got that also hanging over us here.
Excuse me, is he stuck in Hawaii?
No, he wishes he was stuck in Hawaii because he's stuck here not being able to operate, which is bad for all of us.
All right.
So he's back, and we fired up the telemedicine stuff here in the clinic. All the PAs are doing telemedicine. He's actually doing what Dr. Zauzar recommended and speaking to all the patients who've been postponed. We are a very high volume. We've done over 1,000 joint replacements the last 2 years, all with the Mako. So very active, which also means that we've had a chance to reschedule approximately 138 patients from surgery already. So we're trying to come up with strategies that we can treat these people who have been rescheduled with and try and figure out how we're going to go back about getting them back on the schedule. Interestingly enough, our governor yesterday said that we're able to begin elective surgery starting on April 24th, which is next Friday. So all you guys jealous of people that living in the flyover state right now, which usually doesn't happen. That's been a good thing, but we're having to strategize how we're even going to do that because we normally run 2 rooms with 2 gas and we're only going to get 1 room and 1 gas and trying to figure out the logistics of how to make all that happen. So it's going to be a slow trickle back. So we're trying to come up with strategies that we can do. What we decided to do initially was take all of our over 65 or according to the CDC at-risk patients and move them to July and try and get them in the schedule in July. And then we also decided to offer them injections as treatment option in the interim to hopefully allow them to increase their activities, allow them to get outside and walk so they're not stuck in their house in this time of social distancing. It's been interesting. We've had a pretty mixed response of people willing to come in and go through the injection, but the injections are pretty much all we're seeing in clinic right now is a face-to-face visit. I just had clinic this morning and did 6 injections on patients to hopefully help alleviate their pain and give them a chance to increase activity. We here for the last 2 years have been using the slow release steroid injection in clinic. I am a consultant for Flexion as well. We basically sit down with the patients. The PAs see all of the patients in clinic initially. The doc actually sees the H&Ps once they've decided to proceed with surgery. And we talk to them about their treatment options, about traditional steroid injection or a slow release steroid injection. We typically have a 3-month wait for our patients to have surgery anyways. And so about 2.5 years ago, my doc came to me and said that we were no longer going to provide viscous injections because he had lost more than 6 figures in 1 year doing the buy and bill. So I totally understood that, but I asked him, what can I do in the interim for a new patient that presents to our clinic? And I see him and they say, hey, that's great, you need a knee replacement, but our next available date's 4 months from now. So what can we do with physical therapy, with bracing, and what can we do to provide some relief? And so that's where we actually came up with using Zilretta. It's actually changed how I do my practice with traditional steroid injections. I used to have the patients follow up in 12 weeks. The first several injections that I did with the slow release steroid, they came back at 12 weeks and told me they still didn't have any pain. And I thought, well, I'm wasting your time and I'm wasting my time. So now patients that get the slow release injection, they actually follow up as needed and they let me know when their pain starts to return. So we've seen some great success with that and just trying to, increase activities. Just like Alabama, we have a huge percentage of patients here that are obese. We have a huge percentage of patients here that are diabetic and don't even know it. It's not uncommon for us to screen for our A1C. Our cutoff is actually 7.5. And we have people that come in over 10. And we've had patients tell us that their primary care doc told them they wouldn't be able to get below 10. So a lot of that's frustrating and trying to deal with that. But we are trying to optimize our patients while we're in this pandemic and see what we can do so that when we get ready to return to normal activity, whatever that looks like, we'll be ready. And that goes with, like Dr. Sigmund said too, about telemedicine. We're going to continue telemedicine visits, I believe, for at least our 3-week post-op visits and maybe additionally our 6-week post-op visits. The question is, we typically get an x-ray at 6 weeks. And so we'll have to figure out if we want to push that out to 4 months or what we're going to do with that. But we are going to have to try to mitigate how many people are in our lobby initially.